All right. Good afternoon, everyone, and thank you for attending our webinar on ICD-10. Today's presenters are Kathleen Casparo and Melissa Levine. Kathleen is the head of our SWAT department, and she is a certified coder. She has been in this industry for 30 years. And we have Melissa Levine, who is the head of our support department here at Vericle, and she is responsible for over 100 professionals that span 500 practices and post $14 million in monthly payments. So welcome, Kathy and Melissa.
Thanks, Jess. Appreciate that. Just want to welcome everybody today to our ICD-10 webinar. The webinar today will be 30 minutes. The reason why we do this in half an hour, because it's a lot to take in, and if we can deliver our message in 30 minutes to you, of course, if you want additional information from us after the webinar, please feel free to reach out. Just at the end, we'll give you our contact information. So I want to welcome all of you, and I hope that most of you on this phone have not had to dig out 12 inches of snow, but hopefully we can make your lunch half hour at least entertaining. Our focus for today is really understanding the complexity of ICD-10. That is our learning objective. We all know that ICD-10 is coming and it's going to hit us on October 1st, 2014. For a lot of us who are in the healthcare industry, we're actually looking for ICD-10 to hit us on October 1st, 2013, but they gave us a year reprieve. In saying that, though, people actually wonder why are we having conversations so early in the game? Why are we talking about ICD-10 in January? Well, a lot of us have actually been talking about ICD-10 for years. And talking about it early is really the best way to start. We do know that it is coming in 9 months, but in this particular case, if any of you on the phone are familiar with 5010, that was a struggle. This is going to be even more difficult because it's going to involve a lot more people within your practice. So we really want to talk about ICD-10, why it's a problem, and how we have to work together to fix it. So really, what is the problem? Why is ICD-10 such a big issue? And, you're seeing this guy in a car kind of on the edge of a cliff, feeling like he's going to fall over it because everybody's so worried about it. And there is a good reason to worry because it's going to impact you. It's going to impact your practice. Is it going to take away time from your patients? Really, that's what we want to avoid. Everybody's out there to help their patients. You want to help them get better and stay better. What we don't want this to do is really impact your patient care. The purpose for ICD-10 is to improve patient care. The reduction on cash flow. That's something we always have to worry about. Not only reduction in cash flow, the cost of implementing a major change like this into your practice. And everybody always worries about office workflow change. Do I have to hire more people? Do I need different computers? How do I have to upgrade my system? Should I upgrade now? How about testing? And super bills, we do have, people are out there still using paper super bills. Think about it right now. You're looking maybe at a one-page super bill in front of you with ICD-9 codes. We've seen these translations turn from a one-page super bill into, a 10-page super bill. The last thing we want our docs to do is walk around the office with a ream of paper. The new office super bill really should be something that's in electronic format to avoid all of that paper, and you're going to have a difficult time trying to find your codes on 10 pieces of paper. So those are the things, that's why this problem is so hard to solve, because there's so many things that we have to focus on. And one of the other things we have to focus on, and we all, shrug at this, is really the payer readiness. And Jess introduced Melissa in the beginning. I'm actually turning this over to her, and Melissa's really going to talk to us a little bit about monitor paying readiness.
Thanks, Kathy. So payer readiness is one of the other things that makes this just really complicated and a transition that's very hard to handle, because not all the payers are going to be ready at the same time. So the official deadline is October 1st, 2014. Some payers are going to be ready early. So you may have one of your payers that's ready in, let's say, July, another one in August, another one in September. And there's going to be some payers, like we saw with the transition to 5010, though that also had a hard deadline. Some payers weren't ready for months or even years afterwards. One of the things that makes this really complicated is knowing which codes go to which payers.
Yeah, and I agree with you there, Melissa, and I have to say, you and I have been attending numerous webinars with clearinghouses. I mean, how many have we attended, honestly?
Oh, I can't even count at this point.
I mean, here's the question, though. Did we get a clear message from any of our clearinghouses as to when any of these payers or themselves will be ready?
The clearinghouses are starting to have some idea, but based on their contacts with the payer, because most of our clearinghouses have direct contact with key payers, they're getting the message of, we'll be ready when we're ready. And
I love that.
We'll let you know.
I like that message for 5010, and it sounds like we're getting that same message for ICD-10 as well. And, let me just preface that, too, with, we just also had a change in HCFA January 1st, where we went to the old HCFA form, and now we're on the 0212 version, and we still have 3 months to test it before they implement it on April 1st, again, because we have payers that aren't ready to accept the new form that's going to hold 12 diagnosis codes and is going to support ICD-10. So, I mean, that in itself is an example of we're January 1st and we're still allowed 3 months to try to accommodate all the payers that aren't ready. So, yeah, I appreciate that. Monitoring the payers is not going to be an easy task for anybody.
Certainly not.
So we really talk about why it's important. So any change to your practice in terms of workflow is always an important problem because you don't want to change your workflow. You want to be able to continue on your day, implement something new, and kind of keep going. But in this particular case, implementation costs are going to be large, depending really on your practice size, smaller for others. But either way, you're going to have these implementation costs because you have to talk about training. You have to talk about super bills, upgrading your system possibly. There's the need for the steep learning curve. It's going to happen because not only are we implementing a new set of codes, ICD-10 codes, along with that comes with new documentation rules. That's where our steep learning curve comes in, where we have to learn not only a new set of codes, but we also have to learn how to document as well. And turning into that is the increased audits. We're seeing audits all the time. Audits are coming through from Medicare, pre-submission audits, post-payment audits, prepayment audits we're seeing. We're seeing audits on specific CPT codes. If we don't think that the payers are going to increase the audits when ICD-10 comes, we're definitely amiss to what's going to happen here. The reason for the ICD-10 is because we do have specificity and we do have laterality, and the payers are going to be looking for that in the documentation and want to assure that that documentation and the ICD-10 codes match. So a risk of audits is inevitable. It's going to happen. Is there also going to be a higher risk for errors? Absolutely. That's also going to happen. And we're going to give you examples where some codes have underlying codes. So you have to make sure you send 2 ICD-10 codes, or the one ICD-10 code that you send, doesn't matter. Are we going to get denials? Absolutely. Because as Melissa mentioned, these payers aren't ready. And unfortunately, that's going to financially impact us. And again, I'm going to turn it over to Melissa about the billing process disruptions that you're also going to have to face.
So thanks, Kath. And you're certainly going to see some disruptions at the time of billing, as well as afterwards, tying into those denials and errors. Going back to what I was talking about earlier with the payers being ready at different times, every time you go to bill, you're going to have to think about which set of codes need to be sent to the payer for the specific patient you're working with. Does this payer take ICD-10 yet? Are they requiring it yet? Are they only handling ICD-9 still? This is going to be something you're going to have to think about each time you go to bill, because if you send that wrong set of codes and that payer maybe can't handle ICD-10 yet and you send the wrong ones, that's going to be an automatic denial. They're not even going to know what those codes are. And same thing in the other direction. If you send an ICD-9 code and they're, already implementing ICD-10 only, you're going to get those denials, and it's going to slow down your payments.
And I think in all of these together as a whole really are going to have a financial impact on practices, without question. We have to talk about then, we know what the problem is. We know why it's important, because there's a financial impact. There's not being able to treat as many patients as you're trying to implement this new code set and documentation. But the question then is, why is it so difficult to solve, right? We've solved problems in the medical industry in the past. We have advanced technologies. So, why can't we just solve this one? And that's because of the complexity. Because we're moving from 14,000 codes to 68,000 codes, it's a lot. Now, am I going to say that everybody out there uses every code in the ICD-9 book? That would be incorrect, because it's not true. We've become so accustomed to ICD-9 codes that we know where our certain sections are. We know that, codes that start with 8 are injuries, that codes that start with 4 are cardiac. I mean, we can kind of shuffle our way around a book pretty easily. But now we have to train our brains to look at 68,000 codes and now understand a whole new set of rules. But along with that difficult problem to solve in terms of complexity, I mean, in here, yes, we show a funny picture of, were you bitten by a turtle or were you struck by a turtle? Does it make sense? In ICD-9, we do have a lot of these codes. They're E-codes that you would see in your ICD-9 book. But now it becomes even, they want a clear picture, and we're going to get to that. What I'm also going to do right now is actually turn it over to Melissa again about that unfair payer advantage, which, you know what, it irks me every time we talk about it.
It irks me as well, because they make it so hard. They have so much control over what they will take when, and we just have to follow along. And that makes it so difficult for our practices to really have a good handle on what's going on and keep them running smoothly, because they get to say, all right, yeah, I think we're ready now. Oh, you didn't know we were ready? Why not? And because that readiness date is going to change for each of these payers, it just becomes so complicated to try to solve and keep track of everything. And for a practice to stay on top of all that, there's just so much to juggle at one time.
Yeah, and I love the hard deadline for us. I mean, we have to be ready by October 1st, but, the mouse part of the industry can be ready when they're ready, and, it's okay, and they have leeway, but we don't. We have to be able to teach ourselves, which one has 9 and which one has 10, simultaneously while trying to treat a patient, while trying to do our documentation, right? I mean, that's clearly an unfair advantage.
Yes, and we have to be able to juggle back and forth between the two code sets. Well, each payer can just say, okay, we're taking this one now, and we're done with the other. We don't get that flexibility.
Yeah, right. Yeah, I love that part. So, so when we talk about how many codes, I did, just say we can juggle ICD-9. We've had it for tens of years. We've got it. We know these codes. We know where they are in the book. We can say, listen, I'm in the 7th section. I'm in the 8th section. I know what it is. I mean, and you can look at the correlation here on the screen. ICD-9, yes, we can. One clinician would be able to figure that out. But now you're looking at ICD-10. It is such a big burden, because not only are we talking about the length of the code, but we're talking about, we go from 3 to 5 to 3 to 7 characters in length, and we're really trying to represent here the big burden of ICD-10 on one clinician. It's a lot to bear. So we're going to show you and work with you to give you what our approach and our solutions are to this. As we talk and we get to those solutions, we see ICD-9 versus ICD-10. And I mentioned before, because of the advancements with medical technology and the advancements in medicine, ICD-9 can't expand any further. We've outgrown ICD-9. And so ICD-10, as you can see here in the photo, there's a difference. ICD-9 lacks specificity of detail, and it lacked laterality. And ICD-10 provides us with a clear picture of the patient's treatment and what the payers are looking for, which is outcome. Now, is ICD-10 new? It's not. The ICD-10 is used around the world. It's pretty much just new to the U.S. If you were to go to, travel to Europe, you're going to see ICD-10. They've been using it for years. So it's just something that's new to us. But in order to bring that specificity and that laterality to both the patient's diagnosis, coding, and documentation, what they're looking for is better outcomes. That's really the key here, is outcome assessment. We're going to take a code and we're actually going to break it down for you. So, you know, ICD-9, like I mentioned, first digits may be alpha or numeric, like I mentioned, E codes and V codes here. ICD-10, first digits always alpha, and then we break it down. So where in ICD-9, your first code really told you what category it was in. Now your first 3 characters are going to tell you what category that you're in. Then break down the etiology, and then we use our extensions, and most of all, we have these lovely, you know, X's as placeholders. You'll see most of your placeholders, though, in the medications section right now. That's where most of those placeholders are. We find our category, we do our comparison. So we're going to look at a structure here. For example, we have an anterior dislocation of the elbow, which in ICD-9 is 832.01. In ICD-10, we translate that to where the S53 is actually the category that this injury belongs to, which is injuries to elbow and forearm. 0 shows for the anterior dislocation. 14 is for the right, because we're doing laterality, right radial head. And then we have our 7th code, which lets us know if this is an initial encounter, a subsequent encounter, or sequela. That's how we can go out to 7 digits. Again, we're breaking down by category. We can build an ICD-10 code, but we're going from 14,000 codes to 68,000 codes. So we have to keep that in mind. So when, you know, we can have also coding issues when we come across this, and some of those coding issues can be that if a particular code has an underlying code where you have to send 2 ICD-10 codes, where in ICD-9 you would only have to send 1. So we're using it here. Patient has sciatica in ICD-10, but we have to, patient has lumbago. If there's any other underlying reason for the sciatica, we have to mention that as well. So those are potential coding issues where, you know, in the ICD-10 book, it's clearly going to state to you there's a primary ICD-10 code that needs to be coupled with this code. And, you know, those rules are things that we need to pay attention to very closely. And this is one of those potential coding issues. So really what we talk about then, as we've been going over this, is really what's our approach and our solution. For the last, 19 minutes, we've been scaring you with, financial impact, going over documentation, trying to be just as ready as the payers and be one step ahead of them. We have numerous payers out there, and they're not really willing to tell us when they're going to be ready. And we also mentioned about changing your workflow, but we want to give you an approach and a solution that helps solve some of those problems for you. And I'm going to turn this back over to Melissa because she does such an awesome job explaining it.
Thanks, Kathy. Way to set the bar. So we are doing several things in our software to help practices through this change, because it is such a large change. We want to try to make it so that you're not going to have to change the workflow that you're comfortable with and you're used to already as much as possible. So far, we have all of the new codes loaded into our system. We also have loaded the crosswalk tables that are provided by CMS, called GEMS. That is right built into the system to help you convert from the codes that you're used to in ICD-9 over to their equivalent mappings in ICD-10. You get the chance to kind of learn and see that translation right within the workflow you're already using. We're also going to be keeping track, as I mentioned before, one of the things that makes this all so difficult is payers changing at varying times. Our system's going to be keeping track of that through communication with our clearinghouses and with our payers, so that as they make themselves ready for ICD-10, the system's going to be updated with that information. So right when you're at the point of billing, it's going to tell you, based on the payer that's configured for your patient, which coding system you need to be selecting from, or in some cases, both coding systems. In addition to that, as Kathy mentioned, you're going to have your customized super bill that under ICD-9 may be 1 page on paper, and under ICD-10 could go up to 5, 10, or 15 pages. We're going to have the ability for you to put that into an electronic format in our system and have that customized with both versions readily available at the point of billing. I think that's everything that's on there.
So I have a question for you, Melissa. If I have a patient that walks in the door and they have Medicare primary, Aetna secondary, and Medicare's ready for ICD-10 and Aetna's not, we're going to be telling our practices on both the primary and secondary.
We are. We're going to prompt them to select, in some cases, both code sets. It's also going to depend if Medicare is maybe ready but not requiring it. They'll have the option to just pick ICD-9, but they'll know that ICD-10 can be selected.
Okay.
So
yeah.
We're really trying to give you some good direction on what coding sets to pick based on your payers.
Right, and in terms of that customized super bill, like you said, as they crosswalk, as we build up to it, we use that one ICD-10 code example for the fracture, they would be able to choose the category, the etiology, and then be able to, pick their code and whether or not it was an initial encounter, a subsequent encounter, or sequelae.
Yes.
Now, once they pick that code will then be stored on their new ICD-10 super bill, so they won't need to crosswalk that again.
Right. So they may need to if it's a different variation of the same ICD-9 code. They will have the option to do that, but they will also be able to pick it directly from their ICD-10 super bill.
Right. So once they populate that ICD-10 code on their super bill, the patient comes in for a follow-up visit. Do they need to go search for that code again, or is it just going to populate?
It will populate automatically, actually. If they already picked their ICD-10s on the previous visit, those are going to come up automatically on the next visit, and all they would need to do is change it if something about the patient's condition changed.
Okay, yeah, hey, I love that. So, the question is now to yourselves, we've given you our approach. We've, instilled some fear, which I don't like to instill fear, but you know what? I am a certified coder, and I have been working with IC10 for a while now. And it's not getting any easier, actually. So we have to say to yourself, what do we need to do? Going out there ourselves, working with our clearinghouses, they're giving us a 9-step process of what you need to do. Learn the codes, figure out which codes you need to use, contact your vendors, contact your payers, do your upgrades and do your internal testing, get all your intake forms and your super bills taken care of, now do external testing, train your employees, and then wait. Well, everybody wants to sit back and wait, but I don't think that's going to be the case. What we want to tell you is that we're taking away some of those steps. Learn the codes. That has to happen. It's critical that everybody in your practice understands, how these codes work and how they're going to work with your documentation. It's key to understand that. Update your internal processes. Yes, you have to think about your workflow. Yes, you have to think about your internal forms. Conduct training, that's mandatory. Our physicians, any of our clinicians are going to need to understand the new mandates for documentation for ICD-10 that are going to come down the path. And then really wait for October 1st. In that particular case, in terms of waiting, it's become a beta tester. Try to send your claims out when the payers say, listen, we're ready to test on the front end. Do you have some claims that you want to send over to us? I'll let everybody know right now that CMS has put out a notification that they're going to be ready to do front-end testing in March. So as early as March, we can send some, front-end tests to Medicare to see if their front-end edits work well with the new changes, with the ICD-10, and along with the new form, the new HCFA that we have to put out there. So, we talk about it as what we need to do. We definitely need to prepare. The next thing that we want to talk about is really what are your next steps. Always crosswalk your top 50 ICD-10 codes. And Jess is letting me know, Jess, if you can come off mute for a second, HNS for NC users are putting together the top 50 codes. That's nice to hear. Looks like HNS is working with their clients in North Carolina. I appreciate that. I'm from North Carolina. So really what we want to do, we want to assess our top 50 ICD-9 codes and start crosswalking them to ICD-10. So you say to me, well, how do I do that? I don't know anything about ICD-10. The best tools that you can use, you can go to CMS's GEMS, G-E-M-S, and we will be providing links on our blogs along with this webinar for you to go out there and use the GEMS system. And you can also go to aapc.com. They have a neat little crosswalking tool on their website as well, and we're going to provide that link for you too. Again, determine the cost of implementation, and you have to say to yourself, am I on paper? I mean, do I want to carry around, you know, a stack of papers, or do I want to be electronic and be able to have it in front of me and be able to be forewarned when I know a payer is ICD-9 or 10 ready? And, you know, that's part of the implementation and reviewing your internal billing process. What's your flow now? What do you think needs to change? You know, will you need additional staff? You have to think about that. Auditing your sample records. We should all be doing that now anyway. Making sure that our documentation matches both the CPT, HCPCS, and ICD-9 codes we're sending to our payers. But now you really want to learn how to crosswalk your documentation to ICD-10 coding. Is laterality or specificity missing from that documentation? And you have to go back to your clinician and go, you told me the elbow, is it the right or left? Those are things you have to work about. So learning those new mandates, the physicians and the staff should learn them so that you're ready when ICD-10 hits. And then implementing end-to-end testing with payers. For any of your billing software that you have, you know, reach out to them and say, listen, are you beta testing? Can I get on the list? Can I be someone who can send their claims to you in ICD-9 and ICD-10? Get feedback from the payers so we know what's right and what's wrong and start preparing. So really you want to talk to your software company. Like I mentioned, your top 50 ICD-9 codes, I can't say it enough. Start working now because ICD-9 to 10 is not a one-to-one relation, not all the time. You even have ICD-9 and ICD-10 codes that don't even crosswalk to each other. There are some of those out there. So, you know, it's better to find out now what they are and start to get used to using them. Like I said, become a beta tester. Get on Aetna or Cigna. When they say that they're ready, you know, raise your hand and go, listen, I want to test. The other thing we really want you to do here is watch out for our future webinars. We are going to be focusing on ICD-10. It's definitely a passion of mine. I love talking about it. I love teaching about it. The next one that we're going to have in March is really ICD-10 documentation, talking about that laterality and that specificity. So we really want you to kind of, you know, get on board, start preparing for ICD-10, and get yourselves ready for October 1st. So with that being said, Jess, I think it's my time to turn it over to you now.
Thank you, Debbie. All right. I'm going to go ahead and unmute the phone line. So if anyone has any questions, they can speak up. Just give me 1 second.
The conference has been unmuted.
All right. All your lines are unmuted. So if anyone has a question, go ahead and ask it.
Do you have any questions in chat, Jess?
I don't think we have any that I haven't answered. The questions were basically, I mentioned that the webinar would be available on the website. Someone asked if they could actually get the actual slides. I will have to check with our marketing team. I don't believe the slides themselves get posted, but I'm sure she was looking for the examples, and I'm sure we can just send those to her. So if no one has any questions, you can, if you come up with any after the fact, you can post them on our blog, and we will answer them there. And if any of you have come to this webinar hoping to receive your PAHCOM credit, what you need to do is fill out the survey that we sent you. Hello?
Hello?
Yeah.
I just wrote it in, but will we be able to watch this webinar again? Like, is it recorded and we could watch we could look at the slides and listen again? It's kind of a long webinar, but you went at a fast pace. It was hard to take notes.
Yes, the webinar will be posted on the website, and I believe the marketing team is actually going to send you guys another email with the exact link.
That'll be great. Thank you.
All right. So, yes, anyone who wants the PAHCOM credits, fill out the survey. It's really brief. 2 questions other than your name and email. And I'm actually going to mute everyone again because I think it's getting a little hard
to hear myself. The conference has been muted.
And I'd like you to be able to actually hear what I'm saying. So if you do have any questions before this ends, put them in the chat. So anyway, fill out the survey. It's 2 questions, and once you fill out that survey, we will send you the certificate that you can then go onto the PAHCOM website and get your credit for attending this webinar. It's information for you. If you are a member of our service, we have extended hours. We are working until 9 p.m. Eastern here at the training desk, and our coaching services are available up to 10 p.m. Eastern by appointment. That's all, and thank you so much for attending, and we hope to see you in March for our ICD-10 documentation webinar.